is a very good thing which you put in place, because people are wanting to know what POMS is and how it's going to change our practice, and it is going to change our practice. I would say that it's wonderful to have all four chapters together. There's a north, which is Rajasthan and Chandigarh, and there's a south with Lakshmi and Mangla, Telangana and Karnataka. So probably we have a far out reach compared to just us doing it in isolation. Besides that, I think it's a good mix of endocrinology as well as gynae as well as infertility. So to start the year with this is great, and to term it as a masterclass is also good, because we are just picking up a small topic and doing it. So congratulations to all of us for having this webinar.
Thank you, ma'am.
Thank you, ma'am. Dr. Chaitra, are you there?
She is joining. She told me that she will join. I don't know.
So I don't think Dr. Neena Malhotra or Dr. Sweta will be joining. They said, I think they are busy packing up and, planning to move for Eshre also.
Yeah.
Eshre is just round the corner. So should I go ahead and invite the chairpersons?
Yes, please.
I don't have the slides for everyone. The chairpersons for the first talk are Dr. Surveen, Dr. Mangla Devi, and Dr. Nidhi Sharma. Dr. Surveen, we all know very well. She actually does not need any introduction. She's among the brightest stars on the horizon of the Indian Fertility Society. And I was just going through her CV, and she's been bagging awards ever since 2004 when she was a Yuva. So North Zone Yuva Award, and I think there has been no looking back ever since. So
Thank you.
presently she's authored so many books, so many publications, and of course presently she is the senior director and head at Max Hospital, Max Group of Multi-Speciality Hospitals, Delhi and Gurgaon. Ma'am, we are honored to have you with us.
Thank you.
Then we have Dr. Nidhi Sharma. Nidhi has been closely associated with me all along. Again, a very bright star in our Chandigarh chapter of the IFS, and she is the present secretary of IFS and clinically very sound, presently working with Jindal IVF. Dr. Mangla, I don't have her CV just now. Dr. Mangla, may I request you, no offense meant, could you just introduce yourself? We don't wish to waste
Not
time
at
by
all,
waiting
madam.
for
No problem, madam.
Chaitra.
I'm Dr. Devi. So I'm the chapter secretary of IFS Karnataka. I've also been the president of our Bangalore Society of Obstetrics and Gynecology. I'm a clinical director. I have my own IVF center. It's called Smile Baby IVF at Bangalore. Thank you, ma'am. Thank you for having me.
Thank you.
So I would request you to invite the first speaker,
Dr. Varun.
Dr. Varun.
Can I have the CV, ma'am?
Yeah, I'll just project it in a minute.
Chaitra is here.
Yeah, there was some issue logging in. I tried multiple times. It was not happening.
Yeah, that happened with me also.
Yeah.
Has Dr. Varun joined?
Invite Dr. Varun. Oh, change.
Just a minute. Sorry about that.
I
Many
think
things going on.
Dr. Varun hasn't joined yet. No.
Varun has not joined. I'll just give him a call.
Yeah.
Or otherwise, should we proceed with
Or
my
he-
talk rather than wait?
Yeah.
That would make sense.
That would be better.
So
Yeah.
Dr. Loveleen, you will start first, and then
Okay,
I'll try to get.
Yeah.
Is it visible? Is my screen visible?
Your
No,
screen
no.
is visible, but we are seeing Dr. Neela Baheti's.
Okay.
Yeah, my CV is there now.
Yeah.
I
I'll
think
just mute and try to find where Varun is.
Dr. Chaitra has to
Shall
stop
I
sharing.
हाँ
introduce
वो
her?
मैं कर लूंगी
हाँ तभी वो then only Dr. Loveleen can able to share it.
है ना ठीक है
Okay.
हाँ.
Okay.
Should I introduce her? Can you put on the CV or?
Mangla, what I'll do, I'll share the CV to you and then you can just
Okay.
introduce her.
Okay.
So in the meantime, I think I can start sharing my screen.
On
Right?
WhatsApp? You're going to share on WhatsApp?
Yeah, Mangla. I'll share on WhatsApp.
No, not shared yet.
Okay.
Got it.
Should I introduce myself
No,
like
no, no.
I
I've shared
requested
it with
Dr.
Mangla. I
Mangla
don't know
to do
whether.
it?
Yeah, no,
Like I
madam.
requested
I
Dr.
just got
Mangla to
it.
do it.
Dr. Chaitra I think you can introduce.
So I'd like to introduce Dr.
You
Lovely.
have.
She's the Director cum Chief Consultant at Dr. Sodhi's Healthcare, Multi-Speciality Hospital and IVF Center at Mohali, Punjab. She's been the EC member of Infertility Committee of OPSI. She's the EC member of OPSI and Gynae Society of North India. She's the secretary of Greater Chandigarh chapter of IFS, past president of Menopause Society region, past convener of Chandigarh ONG Society. She's running her IVF center since March 2007, achieving results at par with international standards. She has received the IFS Achievers Award at Fertility. She was honored recently on Doctor's Day for her immense contribution to society by Desh Bhagat University and Dr. Z Healthcare. She has received the Amar Ujala Pride of History Award. A keen academician who is invited as faculty to various national and international conferences. Over to you. Over to you, madam.
Thank you so much. Just requesting everybody to just mute their mics so that we can carry on undisturbed. So at the very onset, first thing I would like to say is that PCOS, when we talk about metabolism, we talk about anovulation, we talk about the hyperandrogenic features and diagnosis in adolescence, diagnosis after menopause, but we always forget the uterus. So uterine defects are the forgotten part of the PCOS. And today we will be talking about it. Whatever evidence is available, but we will be talking about it. So in PCOS, ovulation induction restores the menstrual cycles, yet pregnancy rates remain low. And ovulation induction, it gives us the ovulation, but pregnancy rates remain low. And this points to the endometrium and uterus, not just the ovary. Achieving pregnancy also does not always translate into achieving live birth due to higher miscarriage rates and other problems, including hypertension, diabetes, fetal growth retardation, preterm births, etc. So, along with metabolic defects, which are adding to poor pregnancy outcomes, there is evidence that the endometrium and uterus are also at fault. So adverse pregnancy outcomes in PCOS, there are two major papers which have brought out the adverse pregnancy outcomes. Preeclampsia is as high as 2.3 times higher. Gestational diabetes 2.4 times higher. And important thing is preterm birth is higher and miscarriage rates are 1.49 times. The risk of having a miscarriage is nearly 1.5 times higher in these women. And the best data has come from the Bahari Kumami study, wherein they found that even after age and BMI matching, and even after transfer of euploid embryos, the miscarriage odds are as high as 1.49. And another piece of good evidence comes from the euploid matched pair evidence, the study by Lu et al. 67 lean PCOS, so they were not obese, versus 201 controls. Single euploid vitrified warmed blastocyst was transferred. And clinical pregnancy rates were similar, but early miscarriage was significantly higher and live birth lower. So you cannot have more clean evidence than this. So, what are the reasons and what are the problems that can occur in the uterus? Endometrial receptivity could be is deranged, rather. Uterine volume and morphology may be affected. Uterine and endometrial blood flow, then cervical incompetence, and finally endometrial hyperplasia and cancer. We cannot skip talking about this. So the basic defect is hyperandrogenism, the altered LH-FSH ratio, and the insulin resistance. So together, the three of them lead to disrupted estrogen signaling, progesterone resistance, and heightened inflammation. So the epithelial tight junctions are affected. The leukemia inhibitory factor is lowered. Ki 67, the adverse agent is higher. The mitochondrial dysfunction occurs, progesterone resistance occurs. And as a result, we get lower implantation rates. And it has been seen that in the endometrium of PCOS women, the HOXA10 mRNA, which is the very important mediator of implantation, as we know, the levels were 25% lower. In vitro studies also showed that testosterone leads to 50% reduction in HOXA10 levels when the testosterone levels are higher. This was a in vitro study. The end result is altered progesterone receptor A and B ratio, progesterone resistance, disturbed window of implantation, and we get lesser pregnancies and we get more miscarriages as well. What do we do about it? Lifestyle changes, because lifestyle changes will affect the insulin resistance, will affect the other things as well. Insulin sensitizers also probably have a role. We'll talk about metformin more in the coming slides. And there is a case for a more aggressive progesterone supplementation in women with PCOS who are suffering from infertility or pregnancy losses. People have talked about ERA because they say the window of implantation is disturbed, but definitely there is no good evidence that supports ERA for these people. Then the uterine volume and morphology. So the endometrium is thicker in these women, especially those with insulin resistance, but we know that a thicker endometrium doesn't always mean it is a more receptive endometrium. It could be an anovulatory hyperplasia and reduced receptivity. As far as uterine volume is concerned, the evidence is conflicting. Some papers have said that larger uteri are seen in BMI. If the BMI is high, others have found that the classic hyperandrogenic phenotypes will actually have a smaller uterus. But this is very conflicting evidence. Going on to the congenital uterine anomalies in this women. So when I delved into this, it was very surprising that there are a lot of studies which have shown the increased risk of congenital uterine anomalies in the PCO women. These two studies, Chan et al. And Zabrowska, they found that septate and diadelphys uterus was higher. And then another study where they investigated 486 patients, case control study, and they looked for the I-shaped uterus, which is a subtype, a more severe subtype of T-shaped uterus, where the endometrial cavity is actually very narrow. And in women who had infertility or recurrent miscarriage, they looked for the I-shaped uterus. And this anomaly was detected exclusively only in patients who were hyperandrogenic, either with PCOS or with congenital adrenal hyperplasia. So 24.3% and 39.5% in PCOS and congenital adrenal hyperplasia, whereas no cases were found in infertile patients without hyperandrogenism. So, how does this all happen? So, other than the multifactorial inheritance of PCOS, it has also been seen that perhaps it is the environment, the intrauterine environment, which predisposes the female fetus to develop PCOS in later life. So, excessive exposure to androgens during intrauterine life may disrupt the normal fetal development, leading to manifestation of PCOS traits later in life. This, it has been hypothesized, may also be the genesis of congenital uterine anomalies. So the AMH level drives the process of sex differentiation by facilitating the regression of Mullerian duct in males. And in females, until later in pregnancy, the female embryos will not have AMH produced. However, if the maternal AMH levels are high, they may cause disruption of the Mullerian development in the female fetus. So just like the diethylstilbestrol can affect Mullerian duct development, it has been postulated that high maternal AMH and high androgen levels may also do the same harm. And there are studies which have found a positive correlation with of free testosterone levels and the presence of congenital uterine anomalies and also of high AMH levels. From a clinical point of view, current evidence, however, does not justify a routine and universal assessment of uterine morphology in all women with PCOS, which is also recommended by the recent guidelines, the international guidelines. However, in selected clinical contexts, such as women with PCOS presenting with recurrent miscarriage or repeated ART failure, targeted imaging may be warranted to exclude structural anomalies that could adversely affect outcomes. So, if there is repeated implantation failure, recurrent miscarriage, then we should be specifically looking for these abnormalities. Going on to the uterine and endometrial blood flow. So, higher resistance in the uterine arteries was found by a number of researchers, and also the lower endometrial and subendometrial blood flow. Palomba et al., who have done a lot of research in this area, also found a significant improvement accompanying metformin treatment. Others found that hyperandrogenic women were the ones with a lower endometrial and subendometrial blood flow. And whereas this author, Zebrowska, inferred that higher BMI and DHEAS seem to influence the uterine arteries pulsatility index, meaning that there is decreased flow. So this was the evidence for the non-pregnant uterus. For the pregnant uterus, the evidence is more conflicting. There are a number of studies which found that higher uterine artery PI and RI in PCOS women in the first and second trimesters, which may be independent predictors of adverse pregnancy outcomes, whereas others found no difference. So at the end of this, we really are not very sure how much is the uterine artery flow, endometrial and subendometrial flow affected. There is some evidence from the earlier smaller studies that metformin may be able to improve the uteroplacental circulation in pregnant women with PCOS. However, the larger double-blind multi-center trials did not bring out the same evidence. So, the effects of PCOS on the uterine artery PI are not yet fully identified, and the use of metformin for this particular indication remains questionable. Then coming on to cervical incompetence, those of us who are doing IVF always keep on worrying about cervical insufficiency, especially in the PCOS women. And together, they are really a disaster. So some studies have shown that cervical insufficiency is higher in pregnant PCO women, especially South Asian and Black women. Then a correlation was found between higher cervical insufficiency if the maternal androgen levels were higher, or if the woman has conceived with gonadotropin therapy. These are all biologically plausible, but they are all very poor quality studies. They are all confounded by obesity, gonadotrophin exposure, ART exposure, hysteroscopy, twin pregnancy, and the causation has been unproven. So this is a nice systematic review and meta-analysis, a more recent one by Sekar et al. And they, out of a huge number of studies, they zero down on these 3 studies. This study from China, Liu et al., Feigenbaum from USA, and both these studies showed a much higher incidence of cervical incompetence in the PCOM women, 6.5% versus 0.6%, 2.9% versus 0.5%. This third study included only women who had conceived through ART. Here again, the prevalence was higher, but not as much as in the previous 2 studies. So this forest chart again shows that the effect has been seen much more in the first 2 studies, whereas the study which included only women with ART conceptions, or the effect was there, but lesser. So Zhao et al. Tried to find out that who are the women, what are the risk factors where the cervical incompetence is likely to be higher in the PCOS. So they found the highest, as expected, is twin pregnancy and then androstenedione levels, prior gravidity, repeated hysteroscopies. So they could not exactly say how many number, what cutoff, but repeated hysteroscopies was associated with higher incidence of cervical incompetence. And what we keep thinking that this woman has a very high BMI, she's very obese, or the AMH is very high, this had a very much lesser correlation. The odds ratio for the odds for having cervical incompetence was much lesser with this. The more problematic factors were these. So maybe previous abortions could be involved in creating some cervical incompetence, repeated hysteroscopy, and of course, androstenedione levels. So at the end of it, there is no evidence to say that we need to put in cerclages for the indication of just PCOS. PCOS status alone is not an indication for cerclage. However, the high risk subgroups, in them, we should have heightened mid-trimester cervical length surveillance. And we need to just monitor them much more frequently than we would other women. Coming to endometrial hyperplasia, the prevalence of endometrial hyperplasia in PCOS women with anovulation was found to be as high as 35%. And similarly, 30% was the prevalence in women with endometrial thickness more than 9 mm or amenorrhea for 1 year. So the international guidelines 2023 recommend that healthcare professionals be aware of the increased risk of endometrial carcinoma and hyperplasia in women with PCOS, and they should also discuss this with the patient. And endometrial biopsies is suggested or may be considered in women with risk factors, including increased endometrial thickness and obesity. But this later paper, which has come in 2025, actually gives a little different evidence. This was a prospective cross-sectional study, and they biopsied every woman with PCOS, regardless of the day of the cycle, regardless of the thickness of the endometrium, and hyperplasia was 9%. Endometrial carcinoma in situ or the endometrial hyperplasia with atypia was 15% and carcinoma was 6%. So this is a much higher figure, and age was a problem factor. Women with PCOS who had these abnormalities were older, they were more obese. The parity was lesser. So women who had children who were paras had a lesser incidence of hyperplasia and carcinoma. So in contrast to the recommendation by the international guideline, this study found that 17% of women with PCOS who had endometrial carcinoma and 23% with endometrial intraepithelial neoplasia had a normal BMI, and they would have been underdiagnosed under these current recommendations. And they recommend that every patient, or at least we should have more criteria to, and we should be more liberal with the endometrial biopsy specifically to rule out hyperplasia and endometrial carcinoma in these women. They recommended that all women with who are more than 20 years and have any high risk factors should be biopsied. So what can we do about it? Lifestyle and weight, it is the first line. It will always remain first line. That is the recommendation throughout all guidelines and even the latest guidelines, because weight loss lowers insulin and androgens at the source. But there is good evidence for metformin also. And the international 2023 guidelines have suggested, however, that metformin may be used along with clomiphene for a better effect. Metformin alone, we know, is not good enough for fertility treatment, and may be used in IVF in GnRH agonist cycles, but they suggest that the metformin should be stopped when the pregnancy test comes positive. But this more recent trial, the evidence is actually eye-opening. The women who were given metformin pre-pregnancy, and metformin was continued up till the end of the first trimester. In them, the odds of having positive clinical pregnancy was 1.5 times higher, live birth 1.24 times higher, and miscarriage 0.6 times lower as compared to women who were never given metformin or were given a placebo. When they looked at women who were given metformin, but metformin was stopped at the positive pregnancy test, in them the miscarriage incidence was actually higher, even higher than the women in whom metformin was never given. So as per this information, they have suggested that metformin should be continued beyond the positive pregnancy test till the end of the first trimester. And there is an ongoing trial in the UK where they are giving this metformin now up to 14 weeks, but we have to still wait for the results. Myoinositol, it's still considered experimental. There are some benefits, but the evidence is not good enough, so it continues to be experimental. Another trial is going on, which will also give us more information about this. So freeze all in high responders in the PCO patients, we know it grossly reduces the incidence of ovarian hypostimulation. Also, it increases the incidence of live birth. So that is probably the standard of care now. But we must remember that when we do frozen embryo transfers, it carries higher risk of preeclampsia. So natural cycle or ovulation induction protocols for endometrial preparation may overcome this. And once you start doing it, actually, it's not really all that difficult and brings in a lot of benefit for sure. So this is the last slide. What is the evidence? What should we do? What should we weigh and consider, and what we should not do? Weight optimization, lifestyle management, first line, metformin through the first trimester, probably. Freeze all elective frozen embryo transfers in high responders, and natural cycle, modified natural cycle, or ovulation induction for endometrial preparation for frozen embryo transfers. Guideline-based preterm birth prevention, not forgetting GTT and lipid profile. We also must remember the endometrial biopsy to rule out carcinoma and hyperplasia. What can be considered is robust luteal progesterone support in the FET in these patients when we are doing our FETs, or even women who are pregnant with other treatments. Cervical length surveillance in the presence of high-risk groups, and cerclage, however, only in established indication. And ERA is not recommended just because we think that the window of implantation is altered. And cerclage for PCOS status alone is also not recommended. We've had these discussions regarding cerclage and PCOS in our local groups many a time. So I really went into depth to cover this. So these are the key sources and guidelines. And thank you all for a patient hearing.
Thank you very much, Dr. Loveleen. This was a lovely talk. Truly, I felt it was a masterclass, and it shows what a keen academician you are.
Thank you.
You covered everything from anomalies to cancer. And the most interesting thing for me in the anomalies was this eye-shaped uterus. Never heard of it. So I really enjoyed the talk. Thank you so much.
Thank you.
Thank you, Dr. Lovely. Very excellent presentation. Thank you so much for such good clinical insights. Thank you so much.
you, ma'am. Thank you, Loveleen, ma'am. You have covered really very well that this anomalies, congenital anomalies. Actually, I too found it very interesting at first time heard of it. So next time onwards, I'll be more cautious. One thing, ma'am, I just want to ask you, like you said, ki metformin is probably recommended till first trimester only. What about in some patients in pre-diabetic, if we want to continue in second or third trimester, are there any guidelines that we should continue, we should not continue in those
The
kind of patients?
metformin can be continued, but if the patient is gestational diabetes or pre-gestational diabetes, you have to always inform them that the first line treatment, the recommended treatment is insulin.
Insulin only.
But metformin also has a place, or rather, if the patient prefers not to take insulin, they can be
Given
allowed to
metformin.
consider continuing with metformin as long as the sugars are controlled.
And what about the role of ecosprid in patients who are having PCOS to reduce the risk of developing preeclampsia in later part of their pregnancy? Is there any
The
guideline regarding that, ma'am?
I did not specifically come across low-dose aspirin anywhere here, this thing, but that the Aspire trial does include diabetic patients and as one high-risk category where you can give them low-dose aspirin to prevent preeclampsia and hypertensive complications. So that is the Aspire trial,
Thank you so much, ma'am.
It
not
was really a
specifically for
wonderful
PCOS.
lecture, ma'am. Thank you. Thank you so much. It was really wonderful.
If there are any questions in the chat box, I don't think there are any.
There's none actually.
Okay. Thank you so much, everyone.
Thank you, ma'am.
Thank you, Dr. Loveleen, for that wonderful presentation. We have Dr. Varun here with us. In the interest of time, let me introduce him, and I think we'll take the other, inputs of the talk from the chairpersons. Dr. Varun is a consultant endocrinologist at Apollo Hospitals, and also he has his own setup at Spasta Healthcare and Magna Clinics, Bangalore. His MD is from PGI Chandigarh and DM from JIPMER. Research interests include osteoporosis and sarcopenia and diabetes mellitus. He has had multiple awards now. One of the early career forum travel grant Endo 2023 and research grant from ESI and RSSDI. He has got 14 journal publications and 2 textbook chapters. In addition, he is married to one of our FNB fellows. Very nice couple, and I think one of our bright-eyed endocrinologists in Bangalore today. Over to you, Varun.
Thank you, ma'am, for that kind introduction. I'm trying to share my share my screen. Just
On the
confirm.
Zoom, there is a share, and then you need to press.
Yeah.
Yeah.
Hi. Good evening, all. So over the next 15-20 minutes, we are going to discuss about the recent name change of PCOS to PMOS, the pathophysiology, and also the hot topic, the role of GLP-1 receptor agonists. Once like we discuss the name change, then we will look into the pathophysiology. We all know, I will discuss more into detail about the recent updates in terms of PMOS and what could how this could translate into be it evaluation or in terms of management of PMOS, and then we will discuss in detail regarding the role of incretin-based agents. So what's in the name? Yeah, I couldn't help but add this code. But in medicine, it's different. It's important. So it doesn't just shape the diagnosis, how patients perceive the disease, and also for clinicians, when we're trying to communicate, the name matters a lot. There have been a lot of name changes in terms of infectious diseases, which you all know, be it Hansen's disease or be it the other AIDS. Okay, so there have been a lot of name changes predominantly related to stigma. When it comes to field of endocrinology or metabolic health related diseases, so we had seen a lot of such name changes. So when it comes to diabetes, previously it used to be only insulin dependent and non-insulin dependent diabetes, say 2 decades ago. Then once we understood the pathophysiology better, so then we now classify it as type 1, type 2 diabetes, then other forms of diabetes, which includes genetic, like pancreatic diabetes and all, and then gestational diabetes, which or diabetes in pregnancy, which includes the entire spectrum of GDM, like type 1 and type 2 diabetes in pregnancy. When it comes to these is basically related to like pathophysiology. Similarly, like when it comes to diabetes insipidus, like a year ago, 2 years ago, the disease name has changed. Instead of central and nephrogenic diabetes insipidus, now we use as arginine vasopressin deficiency and resistance, which is simple and like we'll be able to, I mean, explain it to the patient. So in most of the endocrinological diseases, if you see, like it will be hypohyperthyroidism, hypohypercortisolism, like it's relatively simple, but there are diseases wherein this naming creates a confusion for the patient. So we should be able to give better clarity with better terminology. So the previous name, like that is PCOS. So there are many issues with the, I mean, this kind of terminology. One is a delay in the diagnosis and also fragmented care. Like when they predominantly come with acne and hirsutism, they will show to dermatologist. When they come along with pre-diabetes, they come to me, like the fertility or like this part, like reproductive part will be missed. And when they're following with gynecologist, then the other metabolic components can be missed. So that's the problem. And also like a lot of patients, when they see the term cis, like I mean, one is there is significant stigma, like when it comes to the diagnosis, not just, I mean, the PMOS, like even in terms of obesity, like there is a lot of stigma in terms of diagnosis and going to a doctor. So comparatively, like PMOS is a better terminology. And of course, there will be a research bias when the name itself is like that. So from ovary-centric approach, like we have shifted to a multi-axial hormone dysregulation. Like that's what like the current name suggests. Polyendocrine metabolic ovarian syndrome, and it's also like a similar acronym which will be easy for patients and also for us to shift over a period of time. So in that Lancet recent consensus statement, like there has been a window of like 3 years wherein overall, like the in terms of EMR and everything, the shift will happen, and there will be a reasonable amount of time. So it should be a welcome move. It has been a long journey. Like so even before Steen and Leventhal described, there have been few publications of similar case presentations. Either these can be like PMOS per se, or it can be related to like hypothyroidism or any secondary causes of like PMOS. Then even in terms of diagnostic criteria, like we had seen a lot, like a lot of confusion, like for everyone. And now relatively like we are clear that it is a spectrum of disease wherein insulin resistance and hyperandrogenism are seen in either of these, like are seen in most of the individuals. The Rotterdam consensus is more inclusive of the entire spectrum of the disease. And in the AEPCVS society criteria, or like wherein hyperandrogenism is given more priority, we tend to include predominantly more severe cases of PMOS, and we will be missing the subtle variants of PMOS. If you look at the cardinal features, this you all know, like in terms of like and the classic PCOS has got maximum risk of metabolic issues and also reproductive issues, and the other like phenotype 2, 3, 4 are like other forms of PMOS. And the cardinal features are, one is anovulation, and then polycystic ovaries and hyperandrogenemia. So when it comes to pathophysiology of PMS, so we can, I mean, simply understand it in this way. So there are issues at three levels. One is at neurohypophysis, like including hypothalamus and pituitary. And there is an issue at the periphery, like at the level of reproductive organs, like both at ovary and also at the adrenal gland. And the third area, like wherein the problem is primarily through insulin resistance at the peripheral tissue, like be it skeletal muscle, be it adipocytes. So there is a dysregulation of the GnRH pulsatility. And we now know with better understanding of basically how the hypothalamus functions, that the pulse generator is now candy neurons, is acronym for like ispeptin, neurokinin, and dynorphin neurons. So there is uh, like change in the FSH-LH basically like a ratio at there. And in the ovary, the sensitivity of because of the hyperinsulinemia that we get in this condition, there is a hyperandrogenism both at the ovary and also at the level of adrenal gland. So, which results in the manifestations. Most of the manifestations or presentations are primarily because of hyperandrogenism regarding the reproductive aspects. When it comes to other clinical manifestations of PMOS, be it increased risk of diabetes, hypertension, ACVD, they are primarily mediated by insulin resistance. So it happens at the pathophysiology is at multiple places. However, in majority of the patients, the insulin resistance is the key driver and present in most of the women with PCOS. So in the latest Lancet paper, like after basically reviewing the multiple publications, even in lean women, the prevalence of like insulin resistance was thought to be significantly lesser. So we now know that like the insulin resistance prevalence like tends to be significantly high, up to the tune of 75% in most of the like women with PMOS. And this insulin resistance is independent of adiposity. Even lean women with PMOS, basically they tend to have insulin resistance. And even those who do not have increased visceral fat, even if their body fat percentage is normal, if they are genetically prone for like insulin resistance, then they can have a PMOS, which we usually see in women with lipodystrophies. This like genetic experiment in front of us in terms of role of insulin resistance in the PMOS. So this insulin resistance which happens is tissue selective. So the serine phosphorylation of like basically insulin receptor substrate, like it leads to the serine phosphorylation effect on PA3 AKT pathway is different and MAPK pathway is different. That's why what we observe like in terms of clinical is at the level of skeletal muscle, adipose tissue, liver, like insulin resistance will be there, and because of that hyperglycemia, like then other ASCVD risks will be there. And when it comes to adrenal glands and ovaries, like they will be insulin sensitive and increased androgen production can happen. And we have, in terms of understanding pathophysiology, like we have evidence in form of the in lipodystrophy patients, like we see like PMOS is a well recognized manifestation. And also like when there is leptin receptor or like POMC knockout animal models, it leads to PMOS and also the other manifestations associated with it. And as you can see in this study, so the individuals who are having PMOS and BMI and fat mass control women, there is no difference in terms of distribution of fat with respect to visceral, abdominal, and like at various components. So it's not just so when a person is like obese or overweight, yes, there will be additional component of metabolic issues in the scenario. But even like in lean individuals with PMOS, there is significant insulin resistance, primarily mediated by the genetics. And beyond the genetic factors, the additional contribution comes from the epigenetic changes which can happen at the time of birth, primarily mediated through a thrifty phenotype. Both in terms of, one is having gestational diabetes or like high blood glucose levels during pregnancy is a risk factor for diabetes at a later age for the kids, that we know. Like similarly, even having hyperandrogenism is a risk factor for PMOS at a later part of age, even if that hyperandrogenism is transient. It's a risk factor for like various metabolic disease and also in terms of reproductive abnormalities at a later disease. So this two hit basically hypothesis. One is this congenital part, which also includes the epigenetic changes, And then we have additional like lifestyle component to that. So this is something like you all know. Okay, so the basically like more recent updates are in terms of one is previously this was not clear like where how does like this GnRH hyperpulsatility come from. Now we know that there is dysregulation at the level of KNDy neurons. So I mean people are trying in terms of giving kisspeptin or neurokinin antagonism or like by addressing it at the level of hypothalamus also like with usage of AMH both in terms of diagnosis or AMH. All I mean, previously we were not clear, but we are also utilizing AMH as a supporting criteria like nowadays. So in terms of therapeutic spectrum, like it's going to improve. For hypogonadotrophic hypogonadism, there are publications with kisspeptin usage nowadays. And the other significant improvement over the past decade has been in terms of understanding adrenal steroidogenesis. So apart from the classical pathway of steroid production, we also have a backdoor pathway, and the I mean most important ones are called as like levodopa-steroids. So there is a specific steroid metabolome. Like if you collect the 24 hours urine for patients with like PCOS or other, if you look at like say Cushing's disease or hyperaldosteronism, each of these disorders, or if you look at the congenital adrenal hyperplasia spectrum, so each of these disorders will have a specific phenotype in terms of the steroid metabolome, and also these can be a target for treatment. And apart from these adrenal steroid related steroid production related enzymes like cortisol to cortisol inactivation enzyme, like which is 11 beta HSD1, there is evidence like which is coming up. So addressing these, I mean, uh, can be one of the therapeutic like mechanism in future. And apart from that, as we had discussed, like so in terms of epigenetics, more and more evidence is coming for all metabolic issues. One is around the prenatal period, and apart from that, regarding the role of endocrine disruptors, it's coming big way. Like last year, like for endocrine disruptors, there was a new guideline 1 year or 2024 or 25, like there was new guideline from like endocrine society USA. So endocrine disruptors are basically significant cause of most of these additional the increasing prevalence of like various autoimmune diseases and also endocrine issues that we are facing now. Then if you are thinking of like any research projects basically regarding the PMOS, these are the areas that you can look for. Then comes the hot topic like incretin-based medications in PMOS. It has been a long journey. So it was discussed almost like at the time of like insulin. But however, the phenomena of basically the there is when we take glucose through intestines versus when we take through uh, parenterally, the glucose response tends to be different, and the primary reason for that is because of these hormones. It's not just GLP-1, GAP, like GLP-2, oxyntomodulin. There are so many hormones, and for us to identify this importance, it took a lot of time. Now we have multiple medications. Like the most common ones that we are using at this point of time are semaglutide and tirzepatide. Semaglutide is a GLP-1 receptor agonist, and tirzepatide is a GLP-1 and GAP coagonist. So how about role in PMOS? So it's predominantly in terms of like action in the metabolic diseases. One is centrally GLP-1 receptors are present in the hypothalamus, which primarily lead to satiety. That's one way of basically mechanism of action. Apart from that, in the periphery, it has action in terms of slowing down the gut motility, increasing insulin production, decreasing the glucagon production. So these changes help in terms of optimizing the glucose levels. And at the adipocyte level, it reduces the adipocyte dysfunction. Adipocyte dysfunction leading to like inflammation is an important pathophysiological mechanism even in terms of PMOS. And this mechanism is very, very important in the entire spectrum of metabolic syndrome. So this also can be addressed with uses of GLP-1 receptor agonists. And when it comes to uses in PMOS, even the receptors of GLP-1 are present on the oocytes, and they're also expressed at the level of thalamus and hypothalamus. As we had discussed, there is multi-axial hormonal dysregulation, so it can act both at the level of hypothalamus and also at the level of ovarian tissue. And of course, by addressing obesity, it can improve PMOS. That's there. So when I mean, there have been animal studies in terms of usage in PMOS animal models, and it improves many signaling pathway when it comes to like folliculogenesis. So be it BMP, like SMAD pathway, or like FOXO1 modulation. So animal based studies had shown significant improvement in terms of the overall reproductive axis. So let's discuss a few meta-analysis. One is usage as per se, like in PMOS, and also in terms of safety regarding pregnancy. So the effects on basically pregnancy rate, and this was one of the first meta-analysis which was published 3 years ago. And when it comes to natural pregnancy, these are again like most of the studies which were conducted were for liraglutide. We have like just one or two RCTs for semaglutide, and although it is a meta-analysis, the number of included studies were like significantly less. So a significant improvement in natural pregnancy rate was observed with GLP-1 RS intervention, and also total pregnancy rate was increased within that short period of few months. When it comes to rate of like IVF pregnancy, there was no significant difference, but the conclusion of the meta-analysis was that probably the duration is not sufficient to improve the outcomes. So when it comes to the specific scenarios, like when it comes to liraglutide, there was one famous study like RCT by Nylander et al., wherein menstrual regularity and ovulation frequency, which have improved. And when it comes to semaglutide, there was more recent like 2025 publication, and also we have one publication in Fertility Sterility just this month. So in the older study, in 2025 study, around 120 overweight obese women were on either semaglutide or combination of metformin and semaglutide. I mean, there was these individuals were observed over a period of 6 months for improvement in body weight, metabolic parameters, and hormonal profile, and spontaneous pregnancy rates, and all the parameters have improved comparison to metformin alone, which is expected obviously because of overweight and obese women. And Lira like has also been studied as an adjunct to IVF or like ICSI at that point of time. Some improvement in like oocyte quality, embryo quality, and clinical pregnancy rate has been noted. So the other common concern like which comes when we are using GLP-1 RS is the safety in during pregnancy. There have been multiple studies. I mean, studies like which have retrospectively seen wherein some GLP-1 ARIA exposure has happened. Till now, like there was no clear association with birth defects. When it comes to the GLP-1 GIP co-agonist, that is twin creatine tirzepatide, as of now, we don't have much data. So to summarize the evidence, when we are considering using GLP-1 receptor agonists or the tirzepatide, so it's better to limit the usage to obese or overweight women with PMOS or with comorbid type 2 diabetes. So in terms of uh, basically regulatory considerations by CDSCO. So whenever there is BMI of 30, it is approved, irrespective of the symptoms, like when the lifestyle fails. When the BMI is more than 27, and if the patient has like a PMOS or any other comorbidity, definitely these medications can be considered and may also help in terms of the fertility potential. And it's important to give contraceptive counseling primarily because we don't have data during pregnancy. And it's better to maintain a gap of at least 1 month when women are planning for pregnancy. And you can look at the increase in number of publications over a period of time. So we have massive amount of evidence in terms of the other issues. Like it's not just approved for diabetes. Now diabetes, obesity, ACVD. It's also approved in USA for MASH LD with MASH. So it significantly reduces the fatty liver fibrosis. Apart from that, tirzepatide has got approval in terms of obstructive sleep apnea, and even in terms of osteoarthritis, they're moving further in the sense that the significant weight loss of 15 to 20 kgs can significantly improve the pain scores in overweight or like obese individuals with significant osteoarthritis. So reproductive, in terms of reproductive physiology also, like these medications are going to come in big way. We have to watch out for that. So to summarize, change of like this name, like from PCOS to PMOS, is welcoming move. I had seen mixed reaction on social media, which is surprising, but actually, like from patient perspective, like from the day one, they will understand that change in lifestyle is important. And as such, in terms of diagnostic criteria or like management, nothing has changed. It's just the message that we send to the patient as a medical fraternity. And pathophysiology of PMOS is multiaxial and evolving, and GLP-1 receptor agonist and the GLP-1 GIP co-agonist, that is tirzepatide, both improve metabolic markers and fertility outcomes. And when we are using in reproductive age women, it's important to have, I mean, consideration regarding pregnancy, and it's better to use contraception and also document medical legally. And in uh, individuals individuals who are non-obese, in those patients, metformin basically like is fine. But when it comes to GLP-1 receptor agonists in lean patients, less, or even when the BMI is less than 27, in off-label treatment, like case to case based scenario, like it's slightly different. But when it comes to uh, open forums, like we advise definitely against off-label usage, but on case-to-case based scenario, like it's up to the wisdom of the clinician. Yeah. Thank you for your patient listening. We can take up questions now.
Thank you, Varun. I think that was a very, very extensive review of the whole thing. I had a question for you. You know, this change in the terminology, for what it has done for the gynecologist is that it's broadened our outlook to PCOS. We
Yes.
think of it in other ways now rather than just the ovary. What has it done for the endocrinologist? How has it changed the endocrinology practice?
Nothing has changed. Usually, like whenever there is a name change, like I had seen few patients basically uttering the word PMOS instead of PCOS. Apart from that, like absolutely there is no change. But I feel it's a welcome move in the sense that patients, they will have this feedback in their mind that I need to change my lifestyle. Often, when they go for reproductive symptoms, when the gynecologist tells to change the lifestyle, and they come as second consultation in terms of frustration. But when the name itself has metabolism like in it, they will, that message is already conveyed.
I think it has changed the patient thinking more than the doctor thinking.
Yes, definitely.
And my second question was that with this GLPA-1 drugs being given, what is the downside to it? Is there nobody talks about the downsides. Everybody is just taking it.
uh, Downside in the sense there are contraindications for that. So
No, would there be an adverse effect? Would there be a long-term adverse effect? Or can I also just take it to lose a few kgs? That's what I'm asking.
so the thing is, like one is sarcopenia, like whenever a person is not actively working on protein intake, and if they're not doing any strength training, which most of the Indians don't do, that
Yes.
we have to agree, it's not there in our lifestyle. Like it takes generations for us to change. But
Yeah.
I can see more of Gen Z, there are two extremes. Like there are Gen Z who are extremely health conscious, and like there are other subset wherein who are extremely like who are getting diabetes at 20s. That's one thing. Sarcopenia is one important problem, like depending upon like age group. The
And is it
other,
reversible? The sarcopenia, is it reversible?
definitely reversible. The concern when we are giving it for short period of time is that the in terms of regain of the weight. So in most of the studies, in whenever like we leave the patients in real world scenario, within 6 months to 1 year, like or there has been, I mean, the longest follow-up was for 2 years. By 2 years, most of the patients gained the mean
Gain back.
weight has came back to the same weight. So it
Okay.
depends a lot on patient I mean, how they are changing their lifestyle. I
And how
have,
long have the studies been there? Like, is it 20 years or how
yeah.
long?
So
Huh?
liraglutide approval was, I think 2007, I think 2003 or 7. It has been a very long period of time.
Okay.
Sema was approved a decade ago, and tirzepatide we have 3 or 4 years of data. So we have a decade, I mean, at least like 1 to 2 decade of follow-up with the older GLP-1 receptor agonists, and
Oh,
the tirzepatide is relatively new. In terms of other molecules, we have actually GLP-1, GIP, and glucagon, other basically incretin-based molecules. Some people are actually taking those also, wherein clinical trials have not been done in the black, both in USA and even in India, like it's happening.
oh,
Few of other in our like basically WhatsApp forums, like few have told that like they were telling that they have already been taking, you manage my side effects. They're coming like that.
oh, okay. Okay,
Sir, I
interesting.
wanted to ask, can we as IVF specialists prescribe this GLP-1 agonist to obese PCO patients, or is it the prerogative of endocrinologists only? Because we are not so much
In
aware
terms
how
of
to handle the side effects of this. And
in
in
terms
US,
of
there have been so many lawsuits against the use of this GLP-1 analogs.
Yeah, I think the good, bad, and ugly part. The ugliest part is that these medications are used by wedding planners, like and also like before marriage and all. Like that's the
Oh my
horrible part.
God.
I feel that the spectrum, like we are getting like I mean, uses of we are getting studies in terms of other diseases also, be it like osteoarthritis, be it like reproductive spectrum. We need to generate more data, and other specialties also should use in terms of legality at this point of time. I think at least like MD medicine and pediatrics, they have mentioned semaglutide is now approved for adolescents also between 12 to 18 years. So in terms of the what's the government like has regulated, there should be a prescription from either MD medicine or like MD pediatrics. That's the regulatory status as of now, but it will change. That's what I feel.
Just today, actually, somebody shared in our COGS group, Dr. Yash had shared that the government of India has restricted use only to endocrinologists, internal medicine specialists, and
Yes.
cardiologists. So
Yes.
this is
Okay.
information that came today.
All of them
Yeah.
are MD medicine.
Yes. Yes.
Yes,
Yeah.
I mean MD medicine can, and specifically cardiologists and endocrinologists.
There's
And
questions in the chat box.
yes, yes.
Dr. Rakhi Goyal has asked, which BMI criteria do you use for prescribing these and anti-obesity medications, standard or Asian specific?
So in terms of again CDSCO guidelines, like standard guide, I mean the Western BMI cutoffs only. Even when they do not fall into that spectrum, when the patients have ASCVD or when they have CKD or when they are having significant degree of MAS LD, all these I mean individuals will significantly benefit. In those patients, we consider these medications for long term, definitely.
And Dr. Yukti has asked, for how many months should we stop GLPA-1 before she conceives? I think you answered that 1 month, you said, right?
1 month is like
But
washout period. Fine.
I
Some
said
I
2.
thought it was longer, 2 to 3 months.
Yeah.
Yeah,
two
even I
months.
heard it was 3 months washout period before we start with fertility treatment.
So for the washout period is slightly different for semaglutide and tirzepatide. For semaglutide, 2 months, and for tirzepatide, the half-life is only 5 days. So it's around 1 month.
Okay.
Okay. And then Nidhi's asked, for how much maximum duration
Maximum.
can we give it?
Again, it depends upon indication. So when we are giving primarily for obesity, we don't define a period at that point of time. Whether they can maintain the weight or not will depend upon the further lifestyle changes. Suppose a patient who has 100 or 110 kgs of weight, once they lose that initial 15 to 20 kgs of weight, they will be able to do calisthenics, like they will be able to move better. Their lifestyle will significantly change. In those patients, on case-to-case based scenario, we can taper the doses and see if they're able to maintain the weight or not. But otherwise, there is no definite period for how long these can be given. When we give for diabetes with other comorbidities, this is like essentially like any other medication. It will be continued indefinitely.
And Varun, the thing is that does it not work on some patients? And is there a time period that,
Yeah.
okay, it's not working, we stop the drug?
So there, in terms of non-responders, if we use at least an optimal dosage for 3 months, okay, and if the patient does not lose at least 5% of weight, then we
Stop it.
basically take it as a non-responder in terms of weight. But even these patients who are non-responders for weight, their inflammation levels come down, their sugar levels significantly improve. So it depends upon the indication why we have started. So suppose if we have started in an individual with diabetes, we will still be comfortable in continuing the medication because that reduces the risk of ASCVD, like kidney issues and all.
Okay.
There are few genetic markers which are coming for like hyper responders and like poor responders, but it's in hardly 1 or 2 publications are there at this point of time.
So what's a hyper responder? Like, what
Hyper
is a
responder is like the average weight loss with semaglutide is around 15%, and it's around 20% for tirzepatide. I mean, even with tirzepatide, up to 25 to 30% like weight loss has been seen. So they respond like very quickly and like very, very good. So that variation is there in terms of response.
This is during how much time?
Over a period of 6 months to 1 year. This entire weight loss is over a period of 6 months to 1 year. Some patients start losing from first, second month only, and in some patients, like it starts gradually.
is this genetic or is it based
Yeah,
on?
there is, in terms of the response to these medications, there seems to be a good amount of genetic basis for that. And but in terms of the lifestyle component, again, like it's very hard to separate in clinical trials unless we are doing in a randomized setting. If whenever we take data from real world setting, there will be some people who are really willing to modify their lifestyle. Some will take these medications, but they hardly just go for walking and all. Like that's all. Like they won't do any strength training. So like quantifying this is a problem in the studies.
Okay, great. Excellent talk.
Very nice, no doubt.
Yeah, bye all.
Thank you so
Very
much
nice
for joining us
presentation.
here today.
Yeah, very nice
Yeah.
presentation. Thank you for the inputs.
So, with this, we move on to the third session for today's webinar, and that is a panel discussion. And the panel discussion will be moderated by our co-conveners of this SIG, Dr. Parul Garg and Dr. Chetra. So, I would like to just introduce them. Dr. Parul Garg has been an executive of the Indian Fertility Society since, I think, 2021. And she also has got the Best Executive Award from the IFS in 2025. The IFS Achievers Award was bestowed on her on 2022 and 2024. She has been given a lot of responsibilities during this time, and I know that she has done very well in each one. And she is a peer reviewer for Fertility and Reproduction, the Aspire Journal, Journal of Obs and Gynae of India, Fertility Science and Research, and she is also the associate editor of the Manual of Assisted Reproductive Technologies and Laboratory Sciences, the second edition, which came out in 2025. So she is presently the librarian of the Indian Fertility Society, executive member of Indian Fertility Society since 2022. and co-convener of SIG PCOS and convener of the quiz committee. And Dr. Chaitra Naik, she is based in Bangalore. She's from Karnataka, and she is and has an MS degree as well as an FNB from the Madras Medical Mission. She's a founder of Kalpa Clinic and myivfdoctor.com. She's also a consultant with the Gates French Foundation and the Strand Life Sciences, consultant with Sanzyme Private Limited. She was the former secretary of the Karnataka chapter, and she has been invited as faculty to a lot of conferences, national conferences, and her special interest is poor responders and recurrent implantation failure. With this, I pass on the baton to our very worthy moderators to invite the panelists, the experts. And before that, I would just like to thank all the chairpersons for both the talks, for conducting the both the talks very nicely, the first two sessions. Thank you so much. Over to you, Dr. Parul and Dr. Chaitra.
Thank you, Dr. Loveleen. Dr. Chaitra, you can invite panelist.
The experts first, just introduce the experts.
Dr. Chaitra is having a series. Dr. Chaitra is there?
Looks like she's having a problem connecting.
I don't have CVs. Okay.
Okay, she had just put them in the group.
Let me check.
Yeah. The faculty group has PPT of all the CVs.
Yes. So Dr. Gauri ma'am का नहीं है.
Dr. Lakbir Dhariwal का तो सबसे शुरू में है.
So we started the panel discussion. Before that, I would like to invite our experts, Dr. Lakbir Dhaliwal. She's a former professor and head Obs and Gynae PG IMER Chandigarh, and a former president Obs Gynae Society of Northern India. Presently, she's a senior consultant at Fortis Hospital and a Milan Fertility Center, Chandigarh. And I would like to invite Dr. Gauri ma'am. She's a director of Ridge IVF and a Fortis and also Fortis Hospital, Delhi. With that, I would also like to invite our panelist, Dr. Anupam Gupta. She is just wait. Yeah. She is a senior consultant at Jindal IVF Center, Chandigarh. She's a former secretary Greater Chandigarh chapter of IFS in 2021 to 2024. And she is a teaching faculty of IFS fellows at Jindal IVF Center. I would like to invite Dr. Rakhi Goyal. She is a life member of various societies and been recipient of IFS Achiever Award 2025, IFS Appreciation Award 2024, and a Hall of Fame in Reproductive Medicine Times Leadership Summit Punjab 2026. I would like to invite Dr. Shruti Nayak. She has done a fellowship in reproductive medicine and a consultant at Archish Fertility Hospital. An area of interest is PMS endometriosis poor responder, and she is a gold medalist in post-graduation. I would like to invite Dr. Karthi Gaini. She is a recipient of SR Youth Icon Award 2026, presented various papers in various national conferences, member of various societies, and areas of interest is poor responder and RIF. I would like to invite Dr. Navdeep Guman. Dr. Navdeep. I don't have CV of Dr. Navdeep. Dr. Navdeep, you can introduce yourself, please. Is she there?
Yeah, I'm there. I'm very much there, Dr. Parul.
Please
So
introduce yourself.
I actually sent it in the group. I have resent it for your just information. So
Okay.
it was there in the group.
Let me check.
I'm reposting it to you, Parul,
Yes.
on
No,
your
I've
personal
reposted it,
chat.
ma'am.
Okay,
I-
Yeah,
great.
I've reposted it.
Yeah, I got it. So, she's a professor, Department of Obs and Gynae, AIMS, Jodhpur. She is a recipient of SR Appreciation Award 2023 and IFS Achiever Award 2022 and 2025. She's a visiting faculty and expert advisor for ART services, AIMS, Nagpur, Guwahati, and Bhopal. I would like to invite Dr. Alekhia. Just hold on. Doctor. I don't have CV.
Hi, ma'am.
I have shared it in the SIT, this one only, na? In the faculty
Yeah,
one.
I got it. Thank you.
Okay, again, I got locked out. I don't know what is happening. Let's see.
Okay. Actually, this introduction has to be done by Dr. Chaitra.
I had to re-log in, re-register. Kuch
It's
to problem
okay. It's
hai.
okay. I'm doing only 2 are left.
That
Dr.
is the
Alekhia
downside
is
of webinars.
Dr. Alekhia is a consultant at Lotus Fertility Hyderabad and visiting consultant Medicover Fertility Hyderabad. And she presented clinical papers and research posters at various conferences. And she was former consultant Apollo Fertility Hyderabad. Now, Doctor, I would like to invite Dr. Ashwarya. एक minute. Dr. Ashwarya. She is a consultant reproductive medicine, Radha Hospital and Fertility Center, Hyderabad. So I welcome you all. So now we start with the panel discussion. It's on ovulation induction in PMOS, the smart and the safe way. So ovulation induction in PMS looks simple, but in clinical practice, this is one of the most delicate areas of the fertility treatment. The real challenge is not just to induce ovulation, but to do it safely, intelligently, and individually. So this panel discussion, we will focus on a practical decision making. So we start with the first case. This is on obese insulin resistance PMS. Patient is 32-year-old woman presented with a secondary infertility since 3 years, and menstrual history, it's lasted for 4 to 5 days every 2 to 3 months, and she often takes withdrawal with the progesterones. Acne, hirsutism, acanthosis, and seen. BMI is 32, AMH is 7.1 nanograms per ml, BP is 130 by 84, HbA1c 6.2%, lipid profile is borderline high, TSH prolactin normal, AFC is 25 on ultrasound. She had tried 4 cycles of letrozole, but there is no ovulation. First 2 cycles were with 2.5 milligram, next 2 cycles with 5 milligram. So question is, should fertility treatment be delayed for the weight reduction? Because she's already trying for 3 years and already tried 4 cycles of letrozole. So anyone can answer, please.
Since
And
her BMI is 32 and HbA1c 6.2 and lipid profile is showing borderline high, and also already 4 cycles of letrozole has been given. There was no follicle growth, no ovulation was detected, and all other parameters are normal. So first choice we have to tell her for lifestyle modification. In the studies we see that even 5% of weight loss will have some metabolic benefits, and also psychological benefits will happen. So lifestyle modification should be given for them. They have to be counseled regarding the diet and exercise. And diet also, there is no particularly like as per their preference, they can go ahead with the diet, but with a consultation with a dietitian. And also exercise also, like a weekly, daily, they have to do a moderate intensity exercise or vigorous intensity activity. And along with that, they have to do the muscle strengthening activities also 2 times a day, in 2 times in a week. So first line will be the lifestyle modification, and then we can go ahead with the treatment.
Okay, anyone can
Doctor,
want to add
yes,
anything?
if I may, so Dr. Parul, as rightly pointed out, the lifestyle modifications are the only intervention that has proven to be beneficial.
Yes.
So in this particular patient, I would like to say that if they have not already tried and have not already wholehearted tried, but because many a times in clinics, we are stuck with the wall. Patients are trying to lose weight and they cannot reduce weight in such a person with this BMI. So I would like to go ahead. But yes, if it hasn't been tried, and particularly if not wholehearted, that yes, I can give her 3 months or so to have the lifestyle modifications if
At
it
least three
does
to
yield
six.
result.
If she hasn't tried, we can wait for 3 to 6 months for
Yes,
doing
yeah.
lifestyle
Yeah,
modification. Yeah.
3 months will give us an idea that whether it's it's on the right
Whether
path
she is
or not.
motivated or not.
Motivate or not. Yes, yeah.
This is more important.
Yeah, more
Anyone?
important. Yes.
Yeah. So we have to individualize according to age, ovarian reserve, BMI, and metabolic health. So consider short delay when BMI is more than equal to 30 and there is a metabolic risk, or there is a insulin resistance, type 2 diabetes mellitus, or obstructive sleep apnea syndrome. And most important, patient is motivated for the safe weight loss. And do not delay if the age is more than 35 to 37 years, low AMH, poor ovarian reserve, long infertility, or male factor. And the target before the ovulation induction is 5 to 10%. Even 5% can improve the cycle regularity, ovulation, and the metabolic profile. So do not let perfect weight become the enemy of a good timing. So we have to individualize. That is the most important thing. And as Dr. Nadeep and Dr. Karthi
And I
already
think we
told
should
us,
stress that the major role is of diet, and about 70% role is of diet, and the
yes,
about only 30% role is of exercise.
exercise.
So
So it
diet should
should,
play a
yeah.
major role in them.
So it
And
should
even
combine,
before
yeah.
ovulation induction, she
Hmm.
should be motivated to lose weight.
That is more important.
Yeah.
Most important, I think.
Yeah.
And
And
is losing weight.
instead of directly putting her on ovulation induction, first step is lifestyle modification.
Yes.
And I would like to ask the patient to come monthly also. It's not like ask the patient to come straight away after 3 months. Then they lose
Very.
that motivation.
Yeah,
Patients
that
are
is very
like, "Ki,
important.
we go to every gynec and they say lose weight and come back." So to maintain the motivation, short targets like maybe lose this much
1 month, two
this
months,
month.
3 months,
Yes,
maximum 3 months.
Like
Yeah.
2 kg every month. We should not
yeah,
set drastic goals for her
yes,
so that she
yes.
gets just depressed.
And
Yes.
counseling about the benefits during pregnancy also.
Hmm.
I think that also helps because patients are more motivated that they might develop diabetes during pregnancy, ill effects on the pregnancy and the baby. They are more motivated by that also.
And most important motivation, she can conceive naturally if she lose weight.
Yeah, there have been many patients who have conceived
Yeah.
spontaneously after weight
Yes.
reduction.
Yeah. So there should be a combination of behavioral strategies like goal setting, self-monitoring, problem solving, assertiveness training, reinforcing changes, and a relapse prevention. And a dietary intervention, there is no evidence to support any one type of diet. It should be a balanced diet and a exercise, of course.
Ma'am, maybe we can even add metformin to help her lose the weight.
Yeah, that we can add for the weight loss metformin. That I am coming to next question only. What is the current role of metformin and anisotol in fertility treatment, and which one you prefer, or you can prefer both? Mm,
If at all the person's BMI is high, then and the previous ovulation induction cycles have failed, then we can start her on metformin and myo-inositol combination rather than one. But if at all her BMI is in the 18 to 25 category and she is a good responder, then maybe delaying metformin might help us.
Okay, anyone want to answer? Should you start the
So,
metformin as soon as a patient is diagnosed with PCOS, irrespective of BMI?
so no,
Ma'am,
I
in
won't like to
Rajasthan,
start metformin just irrespective for every PMS patients.
Mm-hmm.
So, like if I would particularly look for the strong family history of diabetes can be one deciding factor
Mm-hmm.
for the patient.
Mm-hmm.
Other comorbidities in the patient, like if she has the full-blown metabolic syndrome,
Mm-hmm.
which includes obesity as well,
Mm-hmm.
hypertension, obesity, these kind of, and with strong family history, I would like. I'm
Okay.
not very fan of testing insulin resistance because we have varied set of tests and which
Various, yeah.
give varied set of information.
Mm-hmm.
But yes, I particularly would like to choose my patient on the basis of risk factors. Obesity, high BMI, one of them.
Okay. Anyone want to add anything? Everyone recommend metformin first. I mean, this is a drug of choice for everyone.
Yeah, a metformin would be much superior on, I would say, inositol. So they can be
Yeah.
used, but yeah.
Dr. Rakhi, you want to, what is your choice of drug, metformin or inositol?
I use metformin. I agree with Dr. Navdeep what she has said. I don't routinely use metformin, but looking at the profile of the patient, I might add. I generally use letrozole only for ovulation induction,
Okay.
and I might
Right.
add metformin in a few patients. Inositols in a few lean patients, I sometimes use some
Okay.
lean.
Or when there is a GI side effects with the metformin, then we
Yeah.
can switch over to
Generally, if you
inositol.
counsel the patient and slowly increase the dose, it is mostly well tolerated. If you counsel the patient, then well.
Yeah, it's basically how to start the metformin. That is also very important when you advise a patient how to start the metformin.
Should be
I mean, it
started
should
in
be
a low dose,
Started
about
with a lower dose.
500
with the
milligram TPP
500 milligram OD, and then
Hmm.
we have to increment every weekly
weekly.
till maximum dose is
I
2.5 grams in adults.
so I have particularly seen that starting at night also helps. The first dose starting at night,
Right.
then patient have fewer symptoms with that,
And all with the
and then
meals.
keeps yeah.
Sometimes sustained release tablets, they are much better tolerated than the
Yes, they are
slow dose
sustained
form of
release
that.
also. They
Yeah.
are 1 gram
One of my
sustained.
patients was having severe GI effects with
Mm-hmm.
plain metformin. Then when I switched her to sustained release, then she could tolerate it.
Okay. So everyone is recommend metformin first, and our guidelines, international evidence-based guideline on PCOS 2023, also recommended metformin first as compared to inositol in the adults with PCOS and BMI is more than equal to 25, as it has a beneficial effects in metabolic outcomes like insulin resistance, glucose, and lipid profiles. And metformin alone could be considered adolescent at risk or with PCOS, but there is a limited evidence. And BMI less than 25, also they show this is a limited evidence. So this we have already discussed how to start the dose of metformin. And most importantly, use may be associated with the low vitamin B12 levels, especially in those high risk factors for low vitamin B12 like diabetes, post-bariatric or a metabolic surgery, pernicious anemia, vegan diet, where monitoring should be considered. So inositol, as we have already discussed, this is the second line. If there is a GI side effects with the metformin, then we can go for the inositol. Although the specific type, dose, and combination cannot be currently recommended due to the lack of evidence. So this is, we have discussed the international evidence-based guideline, which shows metformin should be recommended as compared to inositol. This is the meta-analysis which shows that the both metformin and inositol are equally beneficial. This is another systemic review and meta-analysis of randomized controlled trials, which shows that inositol is as effective as metformin. Now, as a combination, I could find only this study. This is an Indian study, which includes about 96 patients, which showed that a combination of metformin and minoxidil is superior to the metformin in addressing the menstrual irregularities and improving the insulin resistance. So to summarize, metformin and inositol are adjuncts to improve the metabolic milieu, not a substitute for the ovulation induction. So metformin can be preferred, that we have already discussed, usually a add-on, and inositol is well-tolerated supplement option, may improve cycles and insulin sensitivity, but the fertility and live birth evidence remains limited. So use them to correct the metabolic soil and use ovulation agents to grow the follicle. Now, next question. This has already been discussed by Dr. Varun, the role of anti-obesity drugs and a bariatric surgery. So, in obese PCOS. So, should I discuss or should I skip this question?
You can skip because
Yeah, I think this has been
BMI more
beautifully
than
discussed.
30.
I think this we can discuss bariatric surgery.
Yeah, I mean, especially during and after, what to do probably would be more
And
important.
severe obese females.
Yeah.
So I just summarize this. So anti-obesity drugs, when the lifestyle alone is insufficient, and it should be stopped, as Dr. Varun has already told, 1 to 3 months, depending on the type of drug we are using, and a bariatric surgery in the selected severe obesity or the comorbidities. And a plan of pregnancy should be around 12 to 18 months. Now, what next?
This we can resort to only if we have sufficient time. If this decreased ovarian reserve, we can't resort to this anti-obesity drugs or bariatric surgery because it takes minimum of 6 months for the drugs
Yes,
to have effect, and then
bariatric
3 months
surgery we
washout
need at
period.
least 2 years.
Yeah,
So
and
it
then
should, yeah, this is the
if we
only
have
time.
sufficient ovarian reserve and sufficient young patient, only then we can resort to this.
Yes.
Ma'am, I will say that in very obese patients, this can be considered even in low ovarian reserve because we are not just thinking of ovulation. We have to think about the pregnancy outcomes as well. So I would say that in very selected cases, we may consider in poor,
Pregnancy itself becomes a high risk then. If it
high
is
risk
we
for,
go for the pregnancy in the very obese, severely obese patient.
severely obese patients.
So we have to individualize according to weight also. So she had already tried 4 cycles of letrozole. So what next? And there is no ovulation. Gonadotropins or laparoscopy drilling?
Gonadotropins.
And what precautions you will take when you advise the patient for the gonadotropins?
So gonadotropins have to be prescribed by an infertility specialist, not a general gynecologist, because it requires a lot of expertise. And first of all, we should make the patient aware of the cost of intervention because these injections are costly, and she may have to take about 8 to 10 injections. And then she should be made aware of the frequent visits to the hospital because intense monitoring is required. She may have to come every alternate day, and we usually resort to a low dose step up protocol so that there is no risk of hyperstimulation, and we aim for a monofollicular development. And for this we have to increase the dose in a very subtle way, very slowly. It's a slow dose protocol. So, and also she should be made aware that if there is by chance multifollicular development, we may have to drop the cycle. And even if there is no follicle formation, then also we might have to cancel the cycle. So these things, this counseling should be made beforehand. And even if there is monofollicular development and she ovulates, it's not necessary that it will result in pregnancy. She may be depressed at the end of the cycle that I had ovulated, still I'm not able to conceive. So all these things should be counseled beforehand before she goes ahead with the gonadotropin injections.
So what are the number of follicles you will say, okay, I have to cancel this cycle?
If there are more than 2 to 3 follicles, dominant follicles, at 14 to 15 then we should cancel the cycle.
Okay. Anyone want to add anything? Because I think Dr. Anupam have already told everything.
Ma'am, some places they're also trying step up letrozole. It has worked out. Very few studies are showing step up letrozole or extended letrozole with a little bit of combined gonadotropin towards the end also helps in such patients. Sometimes I've seen.
Okay. That I will come in the following
And
slide.
we can try using a combination of oral plus injectable also
Oral plus
to go at the cost.
injectable throughout the cycle becomes very expensive
Very
for
expensive, yeah.
TI cycles.
Maybe we can add letrozole, and following that we can add gonadotropin in the 10th or 11th days. There is no dominant follicle. Okay.
And adding little bit of if the androgens are too high in her, sometimes adding dexamethasone, a steroid,
Yes, this is one
also
of the
helps.
question I will ask in the following slides. Yeah. So gonadotropins for the ovulation induction, this is a Cochrane review. This suggests that a woman with a live birth rate is 41% with a continued clomiphene citrate, and the live birth with FSH is between 43 to 60%. And what about the laparoscopy ovarian surgery? Is there any role in PCOS patient?
If
In
the
lean
patient is thin,
patient,
if a lead PCOS patient and
Yes.
high LH is there, that patient we
Then
can go ahead with laparoscopic ovarian drilling. But we have to see if there could be any intraoperative, postoperative risk also might be involved. That we have to counsel the patient. And the patient, if they are far away, they cannot come for frequent monitoring. And that patient also, we can counsel them for laparoscopic ovarian drilling. Because the intense monitoring is not required. So
okay,
these are the advantages.
fine. So this
But
is
the
a
main risk is of decreased ovarian reserve post
yes, that
drilling. So we usually don't resort to this drilling.
only in the severe, only in the very rare patient. This is a systemic review on laparoscopy ovarian drilling, which includes 3,000 female patients, and they found that they have experienced spontaneous ovulation along with a significant decrease in ovarian reserve. So this is very important. Whenever we are doing the laparoscopy ovarian drilling, we have to be very cautious. And there is a significant decrease in AMH, LH, testosterone with no significant changes in the FSH and inhibin B. So this we have already discussed.
If Dr. Parul, with your permission, if I may,
Yes,
Dr.
please.
Yeah, I just wanted the expert's opinion as well. If Dr. Lakbir is around,
Yes, yes,
because of her, vast amount of experience that she
yes,
personally has, if she could just put in a few words.
You mean
yes,
to
ma'am.
say regarding ovarian drilling?
Ma'am, between ovarian drilling and, gonadotropins, which would be
And
better?
gonadotropins.
We should not write off ovarian drilling because now with the frequent use of gonadotropins, we all are becoming more expert with antagonists, adding antagonists. So hyperstimulation is relatively becoming much less now. But lean, thin PCOD women, we have to be very, very careful while giving the nanotropins. So if the patient has had lot of ovulation, has had lot of treatment here and there, anyway, you want to see her tubal factor also. So do laparoscopy, histolaparoscopy, and real polycystic ovaries, big ones, thick stroma, and you should not hesitate to do ovarian drilling. Ovarian drilling is not that you drill the ovary, just 3 to 4 punctures only. Just 3 to 4 punctures each ovary. Total, try to do 6 only combined. And after doing drilling, cool down the ovary. And you must cool it before you put it down, definitely. And we did a thesis on this drilling versus gonadotropins, and we got good results in lean, thin PCOD women. The BMI less than 22 in those women, this thesis was done. And you have to be very careful. You should not be aggressive laparoscopic surgeon for doing this. Having respect for the ovaries, you must do just three drills, even just 3 to 4 drills each ovary significantly improves the androgens, because we did all the hormone profile in those cases. So when anyway you are doing laparoscopy, you see big ovaries and she's had a lot of treatment, do not hesitate to do just 3, maybe even 2 to 3 drills each ovary. Even that would be okay. So I would not hesitate to do it if I am anyway doing it very carefully. And regarding otherwise, talking about metformin, yes, definitely metformin has proven its role in the PCOD women. Not only obese, even the normal BMI women also. When you are giving metformin, just give metformin alone for 2 months and then add ovulation induction from 3rd month onwards. And when you're putting them on metformin, every time you have to again emphasize about lifestyle modifications, because lifestyle modifications plus metformin for 2 months and start ovulation induction 3rd month, you will see good results in the women who did not respond to letrozole or clomiphene earlier. They would respond to this. And if the patient conceives on metformin, continue in the first trimester. Definitely. Means we have done the thesis on this also. The women who were continued on metformin, the GDM and PIH were significantly less in those women compared to the ones where metformin was stopped. So I just want to add this much for what all we discussed just now.
Thank you, ma'am.
Thank you, ma'am.
Thank you,
Once
ma'am.
a PCOD woman comes, we should not, we actually feel very happy. Oh, cause is there. Because we
Yeah.
always want to find the cause.
Yeah.
But we should not get thrilled seeing a PCOD woman. Yes, we will give her letrose, she will conceive. Very few of them will just conceive with the letrose in 1 or 2 cycles. Very few. You have to work more on these women.
Like, I mean, if Dr. Parul, as ma'am said, that ovarian drilling is a very viable alternative. If I can add, ma'am, like just in few cases where I think like the patient is anyway going to IVF for other reasons as well, or some other reasons, then that is where probably I can omit drilling and straight away go to IVF rather.
That of course,
Yeah,
that
yeah.
of course you have to give due respect to the ovarian reserve. We all have to give due respect to the ovarian reserve, definitely. But androgens are looked after very well compared to all other drugs. The androgen hyperandrogenism is looked after very well by drilling. But drilling means not drilling the ovaries, just 2 to 3 drills are also sufficient in each ovary.
Not cooking, I mean.
No, definitely no, definitely no,
Not
definitely
cooking.
no.
Yeah.
Thank
And
you.
it should be the anti-ovarian vessel surface of the ovary. It should be the top surface of the ovary where you should be doing the drills. And definitely cool the ovary before you put it down.
Okay, ma'am. Thank you. Now, after counseling with the patient, the ovarian stimulation with gonadotropins were decided in the next cycle. So we have given the patient injection FSH 75 units for 7 days, no response. Increased to 100 for 5 days, no response. Then increased further to 150 for 5 days. There is no response. Then increase the dose of FSH up to 225, then no response. Now what next? Another further investigation to be done, any change in drugs, any pre-treatment, any adjuvants. Anyone can answer?
This might be a case of other causes of hyperandrogenism may also be coexisting. So the DHEAS testing, the 17-OHP, the serum testosterone levels, if at all we get all of that evaluated in the first case, and then maybe deeper tests like receptor polymorphism and all is very rare. So maybe there is other confounding factor also there, or the baseline LH is only very high for these patients. So change, if at all we get to know the reason, we can change that, or else again giving them like 2 or 3 months of weight reduction, and then again restarting the whole with a lower dose and longer treatment again may make them ovulatory if at all the weight loss is consistent.
Okay, anyone want to add anything? I think
If the LH is high, then we can give pre-treatment ocipil, and
yes.
also instead of FSH, we can give HMG, because even though if the LH is high, it might not be active. So we can give HMG, FSH with LH combination, and we can add dexamethasone also from the second day of the menses along with the gonadotropin. We can continue until the follicle becomes 14 millimeters.
Yes. And 17-hydroxyprogesterone to rule out non-classical congenital and adrenal hyperplasia, in which we can start the steroids. So is there a role of dexamethasone in resistant PCOS with normal DHEAS levels? I think we
I
have
mean,
discussed. Yeah.
yeah, 17-hydroxyprogesterone we have tested, and that is where a particular set where we can have dex.
So this is an extended letrozole protocol. This is a study, a small population, 42 cycles, and they have given letrozole 2.5 milligram for first 5 days, no response, then increased to 5 milligram for 5 days, no response, then increased to 7.5 along with the low dose dexamethasone 0.5 for 7 days, and then repeat the ultrasound. They found the dominant follicle and the ovulation. Ovulation rate was increased, although there was no increase in the pregnancy rate. So we can add a dexamethasone in a resistant PCOS patient.
I mean, Dr. Parul, I had that same article, but like it was done on only 42, and that was a
Yeah, this is a very
retrospective, yeah,
small
small,
population group.
yeah,
This
and
is not, yeah.
they didn't test the 17-hydroxyprogesterone as
Yeah,
well.
no. This
I
is just
mean,
normal DHEAS levels. We haven't
dom,
done
yeah,
anything. Yeah,
anything.
yeah. So, this is only 2 questions in this case. Do we have a time?
I
Should I
think we are short
continue?
of time. It's almost Chetra also has to do her cases.
Yes.
So
Okay. So, should I leave? I mean, she can continue.
I think Chetra can do one case and then you can always come back to your case if we have time
Okay,
later on.
fine.
Let's do it like that.
Okay, right. So I just stop sharing.
Yeah. Is my screen visible?
Yes.
ठीक. So we'll have a quick 2 case discussion and probably we'll get back to Dr. Parul. So these are the non-fertility case scenarios. We are going from guideline-based approach. The first case, Dr. Varun has beautifully done. The first case would be discussing about the older woman, and the second case would be the younger woman. Both of these are not desiring fertility. And how does, both of these cases change our practice? All of this has been discussed. Metabolic complications of PCOS in the older woman. We have a 44-year-old lady who has got long-standing oligomenorrhea. She presents for weight loss and sugar concerns. This is a perimenopausal lady. History and examination. We have a PCOS diagnosed in her 20s. She was never fully managed. She was not bothered about pregnancies as well. But in between, yes, she did. She became lucky, became pregnant. Cycles every 2 to 4 months with withdrawal bleeding. Weight gain of around 12 to 13 kgs over 6 years. She complains of fatigue, snoring, and she has got acanthosis nigricans noticed at the neck. Her father has a history of type 2 diabetes and mother is a hypertensive. She is currently on no other medication. She is non-smoker. Her BMI is 36.4, a waist circumference of 104 centimeters and a BP of 146/92. She has a Ferriman Galloway score of 11, which is almost hirsutism. So how would we counsel this patient? Dr. Alekia. Dr. Alekia incidentally is one of our students.
Hi, ma'am.
Yeah.
Yeah. So first we would counsel her to lose her weight, ma'am,
Okay.
because of high BMI.
Hmm.
And we can add metformin
All
because
right.
there's a history of diabetes in her
Hmm.
family.
Hmm.
So my first line would be lifestyle modification with weight loss.
Would you want to do some investigations before you say, okay, come, we'll do lifestyle modification? Because she would have heard this many times. Okay, if you lose weight, then everything will become okay. And these are patients who have desperately tried everything. And that's why the GLP-1, even for us doctors, for us, ourselves, and for the patients, it's one of those things that you just put the injection and weight loss happens. So before that, should you do some investigations?
I will check her HbA1c. I will check her HbA1c levels and.
Okay. You will check her
Her
HbA1c.
full body workup has to be done, her lipid profile,
All
what
right.
is the status of other things. And one more would be, I don't see any recent scan which was done for her.
All
So
right.
the scan has to be done to see what is the status of her uterus, lining, ovary.
Okay. Does Aishwarya want to talk? Incidentally, Aishwarya, Shruti, Karti, and I think Alekhya, all of them are students from Milan. Yes.
Yes, yes.
Yes, Aishwarya.
Yeah, basically, first we want to investigate her with the multimodal treatment, madam. Like, not only us, she has to simultaneously consult the physician as well, so that all the investigations are done thoroughly before we start her on any kind of a therapy. So, first of all, HbA1c, and apart from that, lipid profile, and the other investigations also, like 2D echo and ECG, and also an ultrasound for a start, before we take her to the next level of management.
Okay. So glycemia, as you rightly said, family history. So either 75 grams OGTT or HbA1c, or people do, say HOMA-IR or fasting insulin. All of those, one of those, or maybe multiple combinations of those could be done to find out if there is any glycemia issues. Cardiovascular, because she is at that high risk, perimenopausal, so she kind of becomes the same risk as any man at that age. So get a thorough fasting lipid profile done, blood pressure, weight, or the hip and the ratio between that, the waist and the waist hip circumference should be done, and then you can advise for other lifestyle modifications. Hepatic and sleep are important because she complains of snoring. So find out if there is any issue with the sleep apnea. You could also use this for counseling, that if you lose weight, all of these become better. Androgens, to see if there is any hyperandrogenism, as Dr. Varun had mentioned. Even for a short time, if there was hyperandrogenism, there will be risk of other cardiac and other factors. So thyroid prolactin, 21 hydroxy progesterone, Cushing's if atypical, all of those need to be done. So results drive a stepped multi-target plan. What all would you want to, Karti, the question for you, what all would you counsel her for?
First, I will tell her for lifestyle modification. So her BMI is 36, so weight loss, diet, and exercise is important. And also, if she is resistant, like after doing a active lifestyle intervention, there is no weight loss, we can counsel her for the weight loss injections also after consulting a physician. Like after checking her fundus, before starting fundus and the liver function test, that and all has to be checked, and after consulting them, they can go ahead with the weight loss medications also. And then we have to start on metformin, since there is a family history, and her BMI is also at a higher level. Then we have to access any other risk factors for cardiovascular risk factors are there. Then as per the ultrasound findings, because PCOS always there is a risk of endometrial hyperplasia, so we have to rule out how is the endometrial thickness, and accordingly we have to access to rule out endometrial hyperplasia or anything is there.
Okay. Dr. Navdeep, would this be the patient whom you would counsel for probably GLP-1 if she asks?
I mean, if the lifestyle modifications are not working for her, then
Okay.
yes. But
how
yeah,
long would you say, okay, this long, and then she comes back to you and reports whether it's working or not? How long for lifestyle modification, because before you say it's not working and we go for the medications?
yeah. For
Maybe
her,
6
I will
months.
say, like in fertility, I would say 3 to 6 months. But for her, I can put it for 6 months, because we are not in
Okay.
hurry of some kind, and gradual, because she's at go for a long or moderate exercise. So for her, I will go gradual, with a gradual regime, and I would like to give her 6 months.
Okay. Dr. Anupam, would any other, additional blood test say that she is a better candidate for putting on GLP-1, or would you just agree with what Dr. Navdeep says?
I think 6 months is a good enough time to ask her to be put on metformin and lifestyle modification. And if that doesn't work, then we can go in for GLP-1 analogs.
Okay, provided her sugars are normal. If for whatever reason her sugar is on the higher side, then that becomes two indications: high sugar, high BMI, and all the other things. Probably it would be a bit earlier. If her sugars were suppose abnormal or she is frankly diabetic, maybe a earlier step into getting the GLP-1 probably suggested, with or without metformin, of course, because GLP-1s, I have had a few patients on GLP-1s, they drastically reduces the sugar, so probably stopping the metformin would be wise. Doctor, any expert, any opinion from the experts would be welcome. Dr.
Like we
Lakbir?
are saying lifestyle modifications, but these patients who are not desirous of fertility, they don't have any motivation. So very difficult for to convince them for lifestyle modifications. And 40 plus onwards, it is very difficult to monitor them. I would rather say refer her to Dr. Varun or the endocrinologist. And definitely metformin has a role in this type of. If not GLPA-1, for that we all have less experience and time will make us more intelligent about that drug. So metformin is very good for these cases, definitely. And we have to rather warn her about all the medical problems, cardiovascular, metabolic problems. We have to rather scare her that you are prone to have all this. And we should do pap smear and we should do ultrasound, do the endometrial thickness evaluation. And if it is thicker, maybe endometrial biopsy also should be done in these cases. And that's what I will. But they are difficult to manage by us, such patients.
Yes. They are, even with enough motivation, sometimes they say it's very difficult. That's truly, yeah, I agree 100% on that. Now we go to the next patient. The teaching points here: the older women with metabolic PCOS, it's a lifelong, metabolic risk increases with age and weight even after reproductive concerns end. So use the OGTT, non-HbA1c, not HbA1c alone to detect impaired glucose tolerance. In fact, a few people say fasting, insulin, the HOMA IR, other things. Lifestyle is foundational. Metformin adds glycemic and weight benefit in higher risk women. Probably now GLP-1 as well with more experience, as Dr. Lakby said. Don't forget the BP, lipids, liver, and sleep. Manage absolute cardiovascular risk. And prolonged amenorrhea still needs endometrial protection. So we go to the next patient. This patient is a youngish patient who has heavy menstrual bleeding. She's a software engineer. She's very irritated with bleeding for 10 to 15 days. And this lady has got endometrial hyperplasia in PCOS. So she's a 28-year-old with oligomenorrhea with intermittent flooding. She is seeking fertility sparing care. So young girl with cycles again 2 to 3 months since menarche. Periods now prolonged and heavy with clots and flooding. She has got acne. She's got mild hirsutism. The BMI is 31 kilogram per meter square. She's nulliparous, but she wishes to conceive later on whenever she gets married in the future. She's not on any contraceptive and not on any hormonal therapy for the PCOS. Her hemoglobin incidentally was found to be 9.8 grams on a routine checkup, a well woman's checkup, and she was also told to have iron deficiency anemia. So the risk factors for her would be nulliparous, obese, chronic anovulation, and the core drivers of endometrial hyperplasia. So how would you counsel this patient, Dr. Raki?
Ma'am, I would counsel her that because of this heavy prolonged bleeding is because she is bleeding after a interval of 2-3 months, so it leads to prolonged bleeding. It may be the cause of this iron deficiency anemia also, and later on with this unopposed estrogen can lead to endometrial hyperplasia and future risk of endometrial cancer also. So, along with the lifestyle changes which are needed because BMI is high and she has hyperandrogenic changes also, we can put her on some cyclical progesterone or ocipils till the time she wants to conceive. So it will help with this prolonged heavy bleeding and flooding which she has been facing. So this is how I will counsel her.
Okay.
And along with that, we do all the workup which is required for
Yeah.
the patient of PCOS, the metabolic profile and the family history and everything along with that.
Yeah. Thank you, Dr. Aki. Dr. Alekhya, would you want to do anything immediately? Because she comes to you with a history of, say, bleeding. And these are, suppose a software engineer in Bangalore, she has got good insurance coverage. She insists on doing something. So what would you want to do immediately now that she has come to you? Any tests? For bleeding.
I may consider putting her in for bleeding. Okay. Mm,
Because my
the
first patient I had seen
coagulation
in 20
profile.
who came similar to this, and I did the same thing. And she was like, "No, I need to do something." And surprisingly, we got something else. But if she is willing or if she is sexually active, should you do a biopsy on her?
Yeah,
A
ma'am.
hysteroscopic or pipple or whatever.
Yeah, if she's willing and if she's sexually active, definitely I would consider to do a pipple biopsy, which is an office procedure, which would be easy.
Or
Or
a
a
proper
may
suction would be better.
like
The bleeding will stop immediately.
Now, irrespective, do a biopsy because there were two patients whom I had seen in Chennai. Chennai being more conservative than Bangalore. One person was nulliparous, was not sexually active, but still we went ahead and did a biopsy because we were worried why is she bleeding so much. One more was sexually active, it was more simpler. But both of them had got endometrial hyperplasia. So that's something, and they were young. They were just like probably 13 or 14 years post menarche, but they had got irregular periods. So we should not hesitate doing a biopsy just simply because she's young or she's nulliparous. Always offer that and document it because both of those patients had got endometrial hyperplasia. One was atypical, one more was typical. So we were not worried about, we counseled them. We did refer to our, oncology people, all of that. But important to remember, always offer a biopsy. If the patient refuses, then you just document it. You are safe. It should not be that we didn't offer them a biopsy and that's why an endometrial hyperplasia was missed. So the first important thing would
imaging
be
can
imaging,
go.
as all of you.
Imaging will tell us even if it can be a polyp as well. You never know that the imaging can tell that it's an endometrial polyp. And
yes, it could be, but even without a polyp, if the endometrium is say 11, 12 consistently, especially when you see them on a day 2 or day 3 and they still have a lining which looks like 12, 13, any patient whom you suspect that it could be a pregnancy and a UPT is negative, such a thick endometrium, always do a biopsy. Is better be safe than be sorry. So thickened endometrium, assess for a polyp or fibroid. PCO morphology is often present. That gives one indication that okay, it's not a pregnancy. Endometrial sampling could be as simple as doing a pipple, or it could be a better still would be a hysteroscopy guided biopsy, especially if a higher
normally,
BMI or a failed medical therapy. Yes.
If may I add, like normally we have some patients like just like yours, as you were saying. So what we did as an additional step, because many guidelines say the endometrium of 16 and 18 is fine for these reproductive age group women. So and many with the PMOS lady, it can be that they have a day 2, but that is not exact day 2. That is just a shed through bleeding. So as an extra step, we have added that we give them progesterones and give them a withdrawal bleeding, a proper withdrawal bleeding, and then do a imaging to see endometrial thickness. And if even after a withdrawal, progesterone withdrawal, it is still thick, yes, definitely a biopsy is a good idea.
Yes, and bled for a week and still the lining will be quite thick. So that seems to be the issue. Histology would be hyperplasia. Again, endometrial side, endometrial sampling, biopsy, if it is indicated, there is persistent AUB or prolonged unopposed estrogen, BMI of more than 30 or a failed medical therapy. On histology, if there is hyperplasia without atypia, which is benign, or with atypia, which is malignancy in situ, there is a distinct changes how we treat. The support, of course, is for iron deficiency anemia.
Ma'am,
What are the
excuse
treatment
me.
options,
Instead of
Shruti, if you are around?
Ma'am, instead of simple people biopsy, if we do a proper DNC, it would be both diagnostic and therapeutic also. The bleeding would stop and then we can put her on progesterones. The further management can be done according to the histopathology. But initially to control the bleeding, instead of just people, we can do a proper DNC and a GA.
Yeah, hysteroscopy.
Yeah, that would be still better.
That would be the best one, because even if you do a DNC, it would just sample 4% of the lining. Even
Yeah.
with the hysteroscopy directed biopsy, it would be probably at best, if everything is done, it would be around 40%. So easiest, simplest, if your patient has the money, would be a hysteroscopy directed biopsy. If not, at least any biopsy would be better than no biopsy. And what are the alternatives? What is the treatment that we could give? Shruti, if you are around. If not, Alekia or Karthi.
Ma'am, we can give
can
her on a continuous medroxyprogesterone acetate or OC pills, or we can give, if we can offer her Mirena also.
Okay. How do you counsel her? This is a patient who is wanting to have a pregnancy. When she hears Mirena or copper tea, you'd say it's like a medicated copper tea. How do you counsel her? That's the only question.
Maybe we can just tell, just for 3 months, we'll put her on this and repeat an endometrial biopsy.
Okay.
And then, we can decide after that.
Okay. So
We can say her that
we can say that for
even if at all, even if she's planning a pregnancy, the success rate of the pregnancy will be quite low. The endometrium is quite not receptive. It is always better that we give her some progesterones, and 2 times the people should be negative before we plan on a pregnancy, so that the outcome is also good.
Okay. So
And
generally,
Meprate,
for my patients, if anybody wants to add, if Dr. Daliwal is
Meprate,
around. I'm sorry, I'm standing into the internet drop. So clear up this up.
if there is ACPR, definitely she needs good progesterone that will be LNG intrauterine system, and then do biopsy twice at a gap of 6 months. If that is reversed now, then only one should think of further treatment for infertility. If there is no ATPR, then of course you can think of giving her progesterones and then convince her to plan pregnancy, not to delay that much. But still, she definitely needs progesterone. And if she is planning during this period, and if not throughout the cycle, definitely luteal phase, she needs progesterone every cycle. Definitely.
Thank you.
ATPI is to be taken seriously. Definitely.
Yes, agreed, ma'am. Agreed. Thank you, my panelists, for a great discussion. Appreciate, all the inputs. Thank you very much.
Thank you. Dr. Parul, can you
Yes.
just quickly go through that last case, 2 slides, I think you said you have.
Okay, so I think Dr. Chetra has to do off sharing, then only I can able to share my slide. There's only two
Dr.
questions are
Chetra,
there.
can you stop screen sharing?
There are 2 questions in
Dr.
that.
Chetra, I think, has traveled back home
Yeah.
and just arrived. Can you say the history verbally in the meantime, Parul?
Okay, fine. Just a second. Yeah, this
You can start sharing your screen. She stopped, I think.
okay. I'm just sharing it. Yeah. So this patient, this is a basic case of thin endometrium during letrozole stimulation. Patient is 25-year-old, married for 2 years, keen to conceive, menstrual history 2 to 3 days, and it's every 2 months to 3 months, irregular. BMI is 22, AMH is 7, there is no hirsutism. Semen tubal patency test are normal. Ultrasound, there is a antral follicle count is 24. So first ovulation induction cycle, letrozole 2.5 milligram given for 5 days. And on day 12, her ultrasound showed single dominant follicle 20 mm and endometrial thickness 6.5 mm trilaminar. And there is no previous history of uterine surgery. So would you proceed with the ovulation trigger or cancel the cycle?
I would proceed with the ovulation trigger because there is only one follicle and the pattern is also trilaminar pattern. The endometrial receptivity depends not only on the endometrial thickness, it depends on the endometrial pattern, endometrial blood flow also, and like it depends on that. So if there is no, if persistently, if the endometrial thickness is less, then only we can cancel, or else if we are suspecting any endometrial pathology, maybe persistently any tuberculosis we are suspecting, then only we should cancel, or else we can give the trigger.
Okay, we will. This is fine. I think this is a full
Dr.
answer.
Parul, I think
I
we
mean,
can
but
wait for
just
one more day
consult.
because, hello?
Yeah.
Dr. Parul, I think we can wait for one more day to give the trigger because in letrozole cycles, we can allow the follicle size to go up to 22, 23 also.
Yes,
So
yes,
there
we
is
can
some
do.
improvement in the endometrial lining,
Mm.
and that might increase the endometrial thickness to 7 mm or so. And
Mm.
then after one day, then we can give the trigger, not immediately the next day.
Yes, we can do that because 22, we can wait till next
Yeah,
day.
22. We can
One
wait
day
till
more.
22. Yeah.
Hmm.
Hmm.
So if it is 6.5 and trilaminar good flow, then we can proceed. If second day also, next day also it's same. So this is a case report which shows that factors such as endometrial morphology, type, and blood flow play crucial roles. So there was a successful pregnancy as low as 3.8 thickness was, although it's rare, but it's there. So this is another study which include 868 couples, and this green one is letrozole with endometrial thickness less than 5 mm. They found that the live birth rate is between 4 to 5%, and it's increased to, if endometrial thickness increased to 6 to 8 mm, the live birth rate increased about 6 to 7%, which further increased to up to 7%. So we should not cancel the cycle based on the endometrial thickness if all the parameters are there for the if blood flow is there, trilaminar there, then we can go ahead with the continuation of the cycle. Now, second
I mean,
question.
like Dr. Parul,
Mhm.
like it is just 6.5. It's very at the verge, you know. It
Yes.
might be 6.8 to me, 6.2
Yes, the subject
to
variation are
somebody.
there.
So yes,
Subject
yeah,
variations are
yeah.
there.
So, but so if the pattern is good, I will like to go ahead, definitely.
Yes. And if it is persistently 6.5 mm, and if we wait for 1 or 2 days and then would you add estrogen supplementation?
No, I won't, and not at this point because
Mhm.
two reasons. Because it's unlikely because we are already on day 12 now.
Mhm.
So one day of estrogen won't have any impact.
Or in the next cycle,
So,
you will think of adding the estrogen? If this is first
uh,
cycle, we are
I
finding
mean,
that.
not for a 6.5,
Hmm.
not for a 6.5, yes. But if it is less than 5, I say, and that is with a good follicle and then if everything going on the pathway, but just less than 5 ET. So then I might consider
Adding estrogen.
giving estrogen. Yeah.
Anyone want to add anything? Dr. Raki, Dr. Anupam.
I generally don't prefer adding the estrogen because I believe if it's a good follicle, it must be secreting enough estrogen for the lining to form. We can try changing the ovulation induction agent which we have used, Generally, we see that with gonadotrophins, we have a thicker endometrium, but most of the studies show that they don't make much of this endometrial thickness. When they do the analysis by the uh, agent wise and the thickness wise, then it is not significant. So I don't prefer adding the estrogen supplement. Some of the studies show no difference, and others show that endometrial thickness increases, but it does not result in
Increase
increased live birth
pregnancy
rate or
rate,
a
yeah.
pregnancy rate, and it does not decrease the miscarriage rate. If we
Hmm.
are doing an IVF, then it's a different scenario. If we are doing a
Yeah.
modified natural cycle or a natural cycle, then we can think of adding the estrogen and maybe go for ignore the follicle and go for that NPP protocol. But in a natural trial,
Natural cycle,
I
we
would not prefer.
and
I would
also in letrozole clomiphene cycle, estrogen receptors are blocked. So when we add the exogenous estrogen, it won't have any effect. So maybe you can see the increase in endometrial thickness because that the effect of letrozole and clomiphene has gone. This might be the cause also of seeing the increased thickness when we are using the exogenous estrogen. So as such, estrogen externally is not recommended. And this is a study which is included around 2000 cycles. And they found, although they have a significant increase in the endometrial thickness, but there is a similar rates of pregnancy and a live birth rate, and increased odds of miscarriage. So this is all. This is the second case. So I thank you all panelists. So I would
Thank you.
now we just wind up the session. So I would like to express my heartful thanks to co-convener SIG as a SIG PMS, to our mentor Dr. Suneen ma'am, our convener Dr. Loveleen, and co-convener Dr. Chetra for their constant support, encouragement, and the guidance. My sincere thanks to our chapter secretaries, Dr. Lakshmi, Telangana chapter, Dr. Nidhi Sharma, Chandigarh chapter, and Dr. Mangla, Karnataka chapter, and Dr. Urmila, Rajasthan chapter, for collaborating with the SIG PMS and making this academic initiative possible. I am deeply grateful to our respected chairpersons and our distinguished speakers, Dr. Loveleen and Dr. Varun, for delivering the inspiring talks. And special thank to Dr. Lagbir ma'am for sparing their valuable time and gracing the session with their presence. My sincere appreciation for my co-moderator, Dr. Chaitra, and all our esteemed panelists for informative, practical, engaging panel discussion. I would also extend my thanks to our sponsor, Torrent Pharma, for their generous support in making this program a success. Finally, thank you everyone who joined and contributed to the success of this PMS Masterclass. Your participation, enthusiasm, and support made this event truly meaningful. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Dariwal ma'am. Thank you, my co-conveners. Thank you, Dr. Surveen ma'am, and all of you who joined us here today to make it a success.
Thank you, Dr.
Thank you.
Parul and Dr. Chetra, for such a very to the point panel discussion and case. Very valid ones. Thank you.
Thank you.
Thank you.
To
Thank you,
everybody.
everyone.
It was a very nice learning experience.
Thank you.
Thank you. Thank you.